I'm Jane Hauser, NESCA's Director of Marketing and Outreach, and we want to thank the Falmouth, Hamilton, Wenham, Hingham, North Andover, Northbridge, Northborough, Southborough, and Norwell CPACs for organizing this event tonight. And thank you to all who are joining. It's great to see so many towns and different parent groups involved in educating families on this important topic of anxiety in relation to learning and development, developmental disabilities, and how to address those in an IEP. We'd like to give special thanks to the Northbridge CPAC, who provided funding for tonight's event. Many are aware that anxiety disorders are becoming increasingly common among children and adolescents, especially in the wake of the pandemic. Given the rising numbers of affected children and adolescents, it has become increasingly important that a student's emotional health is addressed both at home and in school. When the students experience a high level of unmitigated anxiety throughout the day, they are less able to learn and meet their potential. Tonight, two of NESCA's expert pediatric neuropsychologists are with us to explore this topic. Dr. Moira Creedon from NESCA's new location in Hingham, and Dr. Erin Gibbons from NESCA's Plainville office. Once we get started, Drs. Creedon and Gibbons will present, and then we'll move on to a live Q&A session. If you have any questions, please feel free to type them in the Q&A tab at the bottom of your screen, but know that we'll get to those at the end of the presentation. If we aren't able to get to all of the questions tonight, please feel free to email me with any leftover questions or reach out directly to Dr. Gibbons and Dr. Creedon. And with that, I will turn things over to our presenters.
I'm going to share my screen with you all and get us in our slideshow. Dr. Gibbons, is this looking okay so far? Okay. So thank you so much for joining us tonight. Dr. Gibbons and I are excited to speak with you about the relationship between anxiety and learning for our students and how to support them through the IEP. We want to provide a little background information about who we are and who NESCA is, so that you can feel comfortable knowing that we bring a lot of information and expertise to you and a spirit of collaboration. So let me tell you a little bit about who we are and our background before we dive into the topic of anxiety. So NESCA was founded in 2007 by Dr. Ann Helmuth. She continues to be our clinical director. And we are really excited to have a number of locations to be able to serve a lot of communities throughout New England. We have our main office located in Newton. We also have offices in Plainville and in Hingham. Dr. Gibbons is the director of the Plainville office, and as Jane said, I'm in Hingham. We also have a Londonderry, New Hampshire office where Dr. Angela Curry is the director, and we have some staff who are also providing services in Vermont. What we're also really proud to provide is services to those students who are living locally or who are living in New England or in the country, but we also offer international evaluation. That's a real passion for Dr. Helmuth. And we're really specializing in evaluation and in treatment and treatment plans for children. And that really goes from infancy up through young adulthood. So we're thinking about more of that across that early developmental period, but all the way up through young adulthood, because we think that's an important time period to make sure that we're servicing our children. We have a couple of core values that are really important to us, and this is why we are inspired to do these kind of webinars to give back to the community, because we care really deeply about the families, the children, the teens, and the young adults that we serve. And because of that, it's very important for us to build relationships and to be extremely collaborative with those around us. And so we are regularly trying to communicate with educators, special education directors, advocates and attorneys, other professionals in the field, because this is really how we gather the most information and how we can be most helpful to people. You know, children don't exist in a vacuum, they're living in a system. And so it's really important to collaborate with the systems of care. We are also at NESCA lifelong learners. So that what that means is that we are constantly trying to learn from other professionals and to really pursue the updated research and best practices in working with children. And that's important for you to keep in mind as we discuss these anxiety disorders and the best practices for educating and supporting our students. And what our goal is to be creative problem solvers, to think alongside families and teams about what will serve students best, and really trying to give practical solutions that people can implement that haven't been tried 100 times. We're really looking for that unique pattern of strengths and weaknesses to help us to evaluate children and teens most effectively. So a few comments on the kind of services that we offer. Both Dr. Gibbons and I are doing neuropsychological and neurodevelopmental evaluations. We also have a team that does transition evaluations for working with those teens and young adults. Dr. Gibbons is also offering diagnostic screening and consultation for students with autism spectrum disorder, particularly when we're really trying to get kids into services, since that the key to success is really intervening as soon as possible. We have an incredible team of transition specialists who provide assessment and post-secondary planning. We have executive functioning coaches that work with us. We do school consultations and observations, speech and language pathologists. We've got a whole team. And a multidisciplinary team is really important to us because we're always learning about the best ways to evaluate and support students at school by taking all this information in. So the kind of kids that we see, which helps us to bridge this conversation and think about anxiety in the learning process. Both Dr. Gibbons and I and a lot of the clinicians at NESCA are seeing kids with learning problems, kids who may have reading problems, including dyslexia, kids who may have dysgraphia or writing problems, dyscalculia or math problems, other language-based or nonverbal learning disabilities, ADHD and executive functioning problems. There's a number of us who work really hard in helping families to identify social communication disorders, including autism spectrum disorder. And my friend and colleague, Dr. Gibbons, is particularly talented in dealing with these really complex children who have medical complications, neurodevelopmental disorders, fetal alcohol spectrum disorders, genetic disorders, if I didn't already say that one. But really in thinking about the really complicated children who may be harder for others to test. That's really Dr. Gibbons' expertise. What I really like to work with in terms of students that fit the profile of students I see would be those who have emotional and psychiatric issues. So I see a lot of students who have anxiety, who have mood-related disorders, depression or bipolar disorder, who've had psychiatric hospitalizations, developmental trauma. And so we see the whole presentation of children. But I will tell you that I feel like anxiety is increasingly common in the students that walk through the door. And even those that I might not diagnose with an anxiety disorder, anxiety is part of so many of these other disorders. So now that you know a little bit about what we do and who we treat, let's move into what our objectives are for the evening. So I will be talking with you a little bit about what anxiety is and what it looks like in children. And then we want to think about broadly, how does anxiety impact our learning? I want to provide you with an introduction of specific anxiety disorders and some of their comorbidities. And Dr. Gibbons will talk to us about how to request support services for anxious children at school and how to understand the different types of school-based services that are available to you. And so those are objectives for the evening. So let's dive in and ask, well, what is anxiety? Oh, excuse me about that one. So what is anxiety? So anxiety is an adaptive response in our brain. It's the subjective experience of fear or of being apprehensive or nervous about something that's supposed to come. This is an evolutionary response. And what happens is our body mobilizes this physiological body-based reaction in response to that danger. So it's designed, this evolutionary biology of ours is designed to keep us safe, to perceive a threat and to respond quickly. This stress reaction, this physiological overarousal, what is happening in our brain is that it sends a signal that we need to get energy to mobilize. And the way that we mobilize our bodies to move away from danger is by increasing our heart rate and our breathing. And really the brain is incredible because it sends fuel to our muscles so that we're ready to run away and get away from that danger. And so this is driven by our sympathetic nervous system. That's that part of the body that is reacting to this form of danger. Now, when we're thinking about a threat approaching us, we don't need to be using higher order problem solving skills. The answer is usually run away from the danger. And so this is why our brain shuts down the unnecessary systems, including our frontal lobes of our brain. And that's the part of our brain that we'll talk about a little bit more in a few slides that really helps us to engage in that higher order thinking. In the moment, we don't need that when we're responding to the danger. Now, when the danger's over, our parasympathetic nervous system picks up. And what it does is it tells us, okay, the danger's away, it's time to calm down. Our heart rate goes back down, our breathing regulates, the brain can divert its energy and attention back to the frontal lobe and be a little bit more available for learning, for consolidation, or for rest. So that is the typical cycle that we see for someone when they're reacting to stress. So what does that physiological activation look like in the body? And so when we think about a stress or anxiety response, the paradigm is that there's three ways we might respond in the moment. We have the fight and the flight and the freeze. Usually when we think about anxiety and anxious children, the first one that we think of is more of the flight, but the fight is there too. And so when we see someone fighting, that's that aggressive response of I'm going to face this threat with a more aggressive reaction, perhaps defiance, some impulsivity, and you can even see some hyperactivity for children because that's that activation kind of coming out. We also have a flight response. So this is, when we think about when this evolutionary biology started, this is the running away from the danger. So we do see some kids withdraw and run away or avoid other things, but kids can also look like flight when they're distractible or they're spacing or they're in some way fleeing the immediate moment to engage in another space. It is also possible for people to show the freeze response in the face of stress and anxiety. This is when we see people who may shut down, who may feel more indecisive or have difficulty shifting gears. So we can, as a group of parents, imagine sitting in rush hour traffic, coming home. If you live anywhere near the Boston area, you know what that feels like. Those times when you're really stressed out about picking up your kid on time. You may have that impulse to yell towards somebody else who just cut you off in traffic. We've got that fight response. You may have the flight of I need to kind of go somewhere else in my mind for a minute because I'm so stressed out about that. Or that freezing of I don't even know what to do. I'm so stressed out in this moment. I might be late for my child. So this fight, flight, freeze is for everybody who experiences anxiety. And the process of this physiological overarousal is not supposed to be chronic. We are supposed to be able to come down from the sympathetic nervous system activation into that parasympathetic, into the relaxed space. Well, what if the danger or the threat doesn't go away? What if that parasympathetic nervous system never had the opportunity to take over? So that can have a real lasting effect on our cognitive resources because our cognitive resources, our brain, is mobilized to protect us from danger and it stays in that state. So what happens when someone is under this chronic anxiety or chronic stress? Well, number one, our attentional systems can be really geared to be on the lookout for signs of danger. We are constantly on the lookout for triggers and other threats that may be in our environment.
Moira, excuse me
Yes.
for 1 second. You have a little bit of an echo. I don't know if there's anything that you can do if it would work better with earbuds or something.
Yep. Okay. I will try that right now. Thank you. Okay, is my audio working okay?
Much better.
Okay,
Yep.
perfect. Thank you so much. Okay, so I was starting to talk a little bit about how our attentional resources are on the lookout for danger. We can also, our body is designed to respond to certain set points, right? For that arousal to be activated. The trouble is when we're under chronic anxiety, we can either respond too quickly to a trigger, we can respond too big right away, or we can become desensitized, and then that reaction takes a long time to generate. Because our frontal lobes, the energy is being diverted away from them, it can distort our perceptions of people or events, and it really limits our ability to engage in creative problem solving, to think flexibly, and to use those frontal lobes in the way that we want them to. We also know that anxiety affects the body. Physiological overarousal is really felt in our body, and we hear that a lot from people that they experience physical discomfort from that sense of the body being really activated. There's research that tells us that there's an impact on physical illness and wellness. So there's all kinds of research that tells us about reproductive problems, hypertension, diabetes. Anxiety is really felt in the body, and it's not uncommon for people to have a lot of somatic explanations for how they're feeling in that moment. So how do we turn off our stress response if we are a person who is over aroused or is starting to have this anxious responding? This is really critical as a precursor to learning, because if our brain is really activated in a state of stress, it is not available to use the frontal lobes. So we know that one of the ways we turn off the stress response is by helping people to feel safe and helping people to feel confident. And so when a person feels validated and protected, safety can be established in relationships. Children also feel very safe when they feel empowered, when they feel like they have some efficacy in their environment, some ability to know what's going on around them, and to feel like they are capable of responding. So some of that anxious responding is about, I'm aware of what's going on in my environment, perhaps, but I don't know what to do. So when a child feels safe, they become more available for learning. They need that to be in that ready position so that they are available in order to acquire new skills and new learning in the environment. So how do we as adults see that children are struggling with anxiety, and how do we help them to turn off their anxious response or their stress response? The problem is that we as adults also get anxious. So we're living in anxious times. As Jane discussed in the beginning when we welcomed you to the webinar, this is the post-pandemic time, whatever that might mean. But the world is also really overwhelming right now in terms of political issues, global health issues, family issues, medical issues. And so what is really hard is that anxious children are contained right now in systems that are also extremely anxious. And so that can be something that's really challenging. So since many of our audience members are educators and parents, I would tell you that what's really important to do is that you take care on that oxygen mask first before we think about taking care of anxious children, including evaluating anxious children. That's an important piece of approaching. So when we are better able to manage our anxiety, we can help kids to do that as well. I want to dive in a little bit more to what anxiety looks like for children, because we've talked about that fight, flight, freeze response in general, but I want to talk much more about what that actually looks like in children, the kind of children that might come walking into my office or Dr. Gibbons' office. So as I mentioned earlier, one of the things that I commonly see is that people imagine anxiety to be the child who is engaging in the flight, who is maybe making a number of trips to the nurse's office or long extended trips to the bathroom. Maybe they're requesting to go home or to call mom, or perhaps even to not be able to go to school. So there's that flight response. The fight response, I see a lot, and others may not recognize this as a sign of anxiety. So this is when children are presented with a trigger, some sort of anxiety-provoking situation, and there may be more of that fight, that refusal or defiance, or that irritability that can come out. Because if we imagine that scenario again, where we're sitting stuck in rush hour traffic, stressed out, we're not the most pleasant and upbeat people in the world. So we can imagine children feeling really irritable in those moments. Students may also feel shut down or be showing the kind of behaviors that include putting their head down on a desk or disengaging from tasks, or perhaps not starting a task. So task initiation is a big thing that comes up often. And if you don't know how to start or you're too anxious with how to start, it can look like you're not engaged in the task, and it's really an anxious freeze response. When these kids and teens go home, well, that's where the fight can come out again, and refusing to do homework and refusing to do chores and battling over all the things with parents or siblings. That flight can look like going up to your room and closing the door, but it can also look like immersing yourself in a video game world or in countless hours of YouTube videos to try to flee or get away from the situation. We can also see kids who freeze, who may feel stuck and have a difficult time solving problems in the moment because they're unable to move on. They're unable to shift and think because they feel somewhat frozen in that moment. So if our kids are this anxious, if this is some of the behavior that they're showing, are they even in that ready position? Are they available for learning? As I mentioned before, that sympathetic nervous system is what is taking over when we're feeling anxiety. And it, as we talked about, it's really diverting our energy away from the frontal lobes in order to mobilize and respond for danger. Well, why is that a problem? And it's because our executive functioning skills live or generally are housed in our frontal lobes. So executive functioning skills, for those of you who have children on IEPs and are in CPACs, you've probably had plenty of presentations about the executive functioning skills. But what I think about is that the executive functioning skills are about how we learn. They're about the process of learning, not the content of learning. So we're not necessarily looking at, do you know a multiplication fact? What we're looking more at is, do you know the process of adding multiple numbers together to arrive at your multiplication fact? Do you understand what's behind it? Do you understand how to break down a problem into small steps? And the problem with turning off our executive functioning skills in our frontal lobe is that that limits a student's access to a variety of really important skills. A big one is in coordinating our attention. That's an executive functioning skill. So if I am a person on the lookout for danger sitting in a classroom, I may be very attuned to the doorway or to the windows, constantly on alert for danger. I may be thinking about what another student is thinking about me when I'm doing my work. My attention is not on the math worksheet in front of me. It's very hard for me to focus and learn when that's where my attention is. Using our working memory is also an important part of our executive functioning skills. I think of that as like the memory waiting room. It's the little pieces that someone may suggest to us. When a teacher is saying, take out your binder, turn to this page, we're doing the even numbered questions. If I'm not attending, if I can't focus on those pieces, it's hard to use my working memory. It's hard to plan the steps to execute a task. It's hard to engage in problem solving. And it's really hard to engage the part of our executive functioning system that we use for emotional control. So what that means is we're estimating the size of a problem. How big of a deal is this? How much do I need to respond in this situation? And our executive functioning skills are really critical to learning because they help us to encode information, to take the information in and organize it. And they also help us to retrieve the information, to pull it out in an organized fashion instead of kind of a jumbled mess. If we're not accessing our executive functioning system, it's really hard for students to be in that ready position for learning. And so we want to make sure that when we're offering supports for students who have anxiety, that we're thinking about ways to keep building these executive functioning skills. These students are often extremely hyper attuned, very over aware of different threats or triggers or their anxious thoughts. And the hard part is when that hyper awareness, that over awareness turns inward, students can get really down on their learning. And this is another barrier to our learning. It can make it really hard to take academic risks, to risk being wrong while we're trying a new skill, which is another way that anxiety can impact our learning process. So if you suspect that your child is anxious, what can you do about that? When students come into my office or Dr. Gibbons' office, what we're trying to figure out is how to differentiate between the typical anxiety or what might be normal anxiety and what might tip the scales towards the diagnosis of an anxiety disorder. So there is some leeway that we give everybody and students in the world, right? We said it's a natural physiological reaction to stress, to have anxiety. And there are times when that anxiety can be pretty short-lived. A school play is coming up, and in the few days beforehand, somebody feels really anxious about it. The first day of middle school is coming up. Those are all expected transitions in time that create a little bit of anxiety. So I'm always asking myself 3 questions when I'm trying to determine, is this an anxiety disorder? One is it persistent? So I'm asking families a lot, does the anxiety last a long time? Has it been months your child has struggled with this or a couple of days? Doesn't mean we don't respond if it's in a couple of days, but it's unlikely to be an anxiety disorder, a separate thing that's going on. The second question I ask is this pervasive? That means, does this problem interfere with lots of areas of functioning, or happen across multiple environments? So that might mean different environments of school and home, which are very different. So it's possible that someone's not showing it in both, but it can also mean different environments within the school. So I'm usually asking questions about, is it only in math class? Does it happen in preferred activities versus non-preferred? Is it happening on the playground or in lunch? Because the goal is to figure out, where is the anxiety bleeding into a student's functioning? The third question that I'm asking is this anxiety excessive or out of proportion? Does this feel like the kind of response that's pretty typical for a student in their position? Or does this feel like it really crosses that threshold to interfere with functioning? And so these are three of the important questions that I might ask. So if you are thinking of a student, or if you have a student who has these qualities, one of the most helpful things we can do is to be as specific as possible with a diagnosis. So many families arrive at a pediatrician's office or a developmental pediatrician or developmental specialist. They arrive at the door of a mental health clinician, school psychologist, therapist, or they may wind up meeting with a neuropsychologist whose goal is to diagnose specific anxiety disorders. I've listed a few here. I'm not going to go into tremendous detail on all of them, or we'd be here until 9:30. So just a few of the ones that we might diagnose for students would be social anxiety or social phobia, generalized anxiety disorder, selective mutism, also developmental trauma or PTSD, post-traumatic stress disorder, obsessive compulsive disorder, and separation anxiety. And these are just a few. There are other anxiety disorders, but these are the most common ones I would say that I often see for students that come into the office. Anxiety is a little bit friendly with a lot of other things out there. And so anxiety is often a comorbid diagnosis. And what that means is that we might diagnose anxiety alone, or anxiety might happen in conjunction or in combination with other diagnoses. And so this is something that we're regularly thinking about for students. When we look at the statistics for anxiety disorders, the most common comorbidities are other anxiety disorders. So for students, it may mean that they have a specific phobia, for example, of spiders, and they may also have social phobia or social anxiety. And so in that case, we can diagnose both. One really common comorbidity with anxiety are mood disorders. It's pretty hard to feel anxious all the time for many years and not feel really sad and down and disappointed about that. And so I think that's a very common comorbidity and one we're keeping an eye on a lot. And anxiety disorders are also very common in those who have tic disorders. So that could be a vocal or motor tic, or Tourette's, which would be a combination of multiple tics. Anxiety also comes along with, or we see often as a symptom for students who have autism spectrum disorder or other neurodevelopmental disorders. It depends on a person's unique situation to see do they qualify for a diagnosis of autism spectrum disorder and an anxiety disorder, or is their presentation kind of under that umbrella? And that gets down to oftentimes the question of what their presentation looks like and what's most relevant for treatment. Anxiety is really common in students who have ADHD and those who have behavior problems. And really where we see anxiety a lot is for those who have learning disorders or difficulty in their learning, because that process can be incredibly anxiety provoking to feel like you're in a classroom all day with either pacing or tasks that exceed your skill level. So before I turn it over to Dr. Gibbons, anyone who joined us late, I'll remind you that we're going to have a Q&A at the end. And so because of the size of our group, we are going to just ask you to put questions in the Q&A section, and we will try to get to them as best we can at the end. So I will turn it over to Dr. Gibbons.
Thank you. Okay, let me know if the volume and audio sound okay. If anybody's having any problems, let me know. And I will warn you that I may be little heads may poke in a few minutes when they come up for bedtime. So I apologize in advance if that happens. So now that we have sort of a better understanding of the different anxiety disorders and what that looks like for students in school, I'm going to talk a little bit about how to address it through the IEP, or sort of through school services, and how parents can advocate for some help around these. And I'm gonna, since Moira is sharing, I'm gonna have to tell Moira, you can switch to the next slide. So as you know, I know a lot of you probably have students on IEPs or work in the education system. So there's this, eligibility flowchart that students go through in order to determine if they are eligible for an IEP, which would mean they require specialized instruction or related services in order to make effective progress. And as many of you, I'm sure, also know, one student can have multiple disability areas documented in their IEP. So a lot of times, especially if we're seeing a student who's a little bit older, like school age or middle school age, if they have a learning difference or ADHD or autism spectrum disorder, that's often been identified earlier, and maybe they already have an IEP for that issue, but now the parents or the teachers or whomever is getting more concerned, like, they're still not like really engaging. They don't talk in class. Maybe the trips to the nurse are getting more significant, that kind of thing. And so if, Dr. Creedon or one of the other neuropsychologists or someone is diagnosing an anxiety disorder in addition to something else going on, I always encourage parents to have that documented in the IEP. So like, okay, we know about the dyslexia, they've got the specific learning disability on their IEP, but we also need to capture this anxiety disorder through an emotional disability as well, because just working on the reading isn't necessarily going to address the anxiety anymore. It's sort of like we've been working on the reading and this student is still really anxious. So we're talking about, sort of needing additional supports. And this is when, we are sort of like Dr. Creedon was talking about, that anxiety being more pervasive and really starting to impact the student at school. I would say the number of school refusal cases that we've seen at NESCA has really increased since the pandemic. And that would be, obviously a pretty big example of when the anxiety is really interfering with a student's progress. And so making sure that that is being captured in the IEP is important. So you can go ahead to the next one, Moira. So, as we think about, so if let's say it's a first time IEP, right? And the first question on the IEP flowchart is like, does this student have an identified disability? And if you're coming in with some kind of anxiety disorder diagnosis, then the answer to that would be yes, they do. And then the second question is, does the disability prevent the student from making effective progress? And so I just want to remind everyone that effective progress does not just mean academic progress. We see plenty of students who come in and all of their academic achievement scores are in the average range on our testing, but they are having meltdowns every day. They are fighting with their siblings. They are talking back to teachers, getting detentions, like lots of other things are happening that, even though, sure, they can do grade level academics, but we're seeing all of these other things happening because of the anxiety disorder. That means they are not making effective progress. So making sure that you're looking at the whole child. So, or we've got, the students who are becoming socially withdrawn, isolated, things like that are happening. And again, like, if they can do grade level math, that's great. But if they're like coming home and crying every night and parents are dragging them to school in the morning and things are getting worse and worse, like they're not making effective progress, right? So we need to address that in those cases. So thinking about sort of levels of support, so you can go ahead to the next one, Moira. So there's sort of different tiers. Yeah, thanks. So sort of at the, I guess, lowest tier of intervention, we're thinking about classroom-wide supports. So these are things that general education teachers can do. So these might be students who sort of have some mild anxiety, maybe didn't meet criteria for an IEP. Maybe they have a 504 accommodation plan, or you can just be, if you're a parent who sort of communicates with your classroom teacher, your student's classroom teacher, these are things that can sort of be done. And honestly, I think are being done more and more because of so many students being anxious post-pandemic. And I know just in general, like my husband's a high school teacher, and the amount of professional development that's being done on social emotional learning in the last few years, I think has really increased. So I think a lot of general education teachers are getting a lot more of this training and understanding of just things that they can set up in their classroom. So like Dr. Creedon was talking about earlier in what can we do to address the anxiety, creating a safe, predictable classroom is really important for students who experience anxiety. So giving warnings about transitions coming up, where math is going to be wrapping up in 5 minutes, and then we're going on to music or whatever, making sure that students sort of know the plan, have those warnings, know when they're going to be moving along. A lot of kids with anxiety, part of that sort of freeze response would be that like getting stuck, having a hard time with transitions, maybe trouble moving between activities. So having the schedule posted, somewhere in the classroom that they can refer to, having the routine be very predictable. I see a lot of, at NESCA, we do a lot of classroom observations. And so I see a lot of classrooms where they're like, these are the classroom rules. And it's things like, be kind to each other, be respectful, things like that. And I love when I see things like that, because it's sort of like a contract among the students, and the students know what the expectations are and understand the rules. And that helps create that feeling of safety, and like their teacher, is going to support them when they are maybe having a hard time. So then there are specific programs that have been developed to support students who have anxiety, whether it's full-blown some kind of anxiety disorder or just kids who experience sort of mild anxiety. So for younger kids, some of the popular ones that I see a lot are the zones of regulation and how does my engine run? So, I'm sure a lot of you are familiar with the zones, but there are different colors associated with different moods. So blue is sad, green is when you're like ready for learning, you're kind of feeling good. Yellow is when you're starting to get escalated. And then when you're in the red zone, it means you're sort of not available to learn. So I see this a lot in elementary schools more and more, where they're just using that with the whole school, and it's helping kids get in touch with what they're feeling, especially when teachers, do a check-in every day. It's helping students gain some awareness about what's going on for them internally. What does that mean? What can you do when you're in the red zone? Things like that, which can be really helpful. And a lot of occupational therapy, I think it was developed by an occupational therapist, if I'm not wrong. And so a lot of OTs will do, some support around this in the classroom. And then how does my engine run? I think was more for kids with ADHD initially, but it also is helpful for kids with anxiety. And it's also kind of helping with that self-reflection and self-awareness for kids who may be struggling to keep their sort of at a level. Here's my little helper. James, can you go in with Daddy? Speaking of ADHD, so how does my engine run? Sort of, again, like kids noticing when they're either too high or too low in their energy. And then the social thinking curriculum was developed by a speech and language pathologist, and it's often used for kids with autism spectrum disorders, but I've also seen it used effectively with general education students, where it's again sort of recognizing when what you're feeling and thinking is starting to affect how you behave and how that's affecting your relationships with other kids. So for anxious students, I think that program can also be helpful. So these are things, again, that if general education teachers have the tools and some training, these are things that can be implemented with the whole classroom. It doesn't have to be sort of a pull-out services. I see a lot more, I think there's been a big push for like sensory equipment in the classrooms and giving students a safe space. So having like a calming corner or a little calm down area in the room where students can go, trying to get rid of some of that stigma around, you have to go to the counselor's office every time you're feeling anxious. If it's just like, this is part of the classroom and everybody can use it. And there's usually like fidgets and a beanbag, and it's maybe just sort of a little bit away from the other kids. This can be, these are sort of tools that you can be asking for in the classroom that are not, a significant, like I said, sort of a significant like pull out where someone would need to get involved. in the classroom. And then, having things like movement breaks. I see a lot of teachers incorporating like brief meditation or some mindfulness exercises with their students, which can be really helpful. Doing like a little bit of yoga, things like that throughout the day can help students self-regulate especially when they're feeling anxious. And then, I think just for general education teachers to get consultation that they need from the school psychologist, or if a student has an individual therapist, thinking about these are things that you can implement to support your students who have anxiety. All right, Maura, I'll have you can go to the next one. So if a student does meet that threshold where they have an IEP, they've been found eligible for an IEP, and so the emotional disability is now being captured, then you want to think about having goals and measurable benchmarks that are targeting specific strategies to help the student start to manage their anxiety. And of course, what those benchmarks look like, it's going to depend a lot on the student's age, their developmental level. For a first grader, we might be talking about things like using the zones of regulation, helping them notice what mood they're in, letting someone know when they need to take a walk, things like that. For an 11th grader, the benchmarks might be more like, seeking out the counselor, engaging in, more like traditional sort of talk therapy or counseling. So it's going to depend a lot on where the student is developmentally. But the goal, this would be true if we have an IEP goal for any areas, we want the benchmarks to be targeted skills and that are measurable so that we can track the student's progress. Because obviously, if a student has the same benchmark for coping skills for 3 IEPs in a row and it's not getting better, then we've got to be like, okay, something is not clicking here, we've got to do something about that. And then the intensity of the services that the student needs is going to be driven by how significant the anxiety disorder is. So yeah, you can go ahead to the next one, Maura. So so when we think about like, okay, so if we've got the IEP, what are things that we should be asking for? What are things that are available? What should we be thinking about? So for those of you who sort of know how the IEP is written, there's the accommodations come before the goals. So as we're thinking about accommodations for students with anxiety, some of the things that I was talking about a couple of minutes ago can be captured in the IEP. So say, sometimes I'll see things where maybe a student has to like earn a break or earn a walk or something like that. And I would say, this student needs the accommodation where they sort of have unlimited access to breaks because they're so anxious. They can't necessarily wait until 11:15 or until they've done all of their math worksheet or whatever it might be. If a student is experiencing anxiety that's not related to some kind of challenging behavior, that would be, an example of an accommodation. Or for students who do have a lot of physical complaints related to anxiety, we might be talking about access to the nurse. I've had kids who have GI issues related to anxiety, and maybe they have access to the nurse's bathroom because they're embarrassed using the student bathroom. So there are a lot of accommodations that would be captured in that section of the IEP, or things in that are going on in the classroom. And then similar for testing. So this would be, obviously for older students who are starting to have tests in class. So, you might be thinking about a student needing a quiet setting when they take tests because they get too distracted and anxious when they see other kids finishing before them. We see a lot of anxious kids who need extra time on tests because they sort of freeze up and maybe spend the first 30 minutes like hyperventilating and then they get started and they've lost half the period, so they might need extra time. Or conversely, we have those anxious kids who would just sit there and check every answer 17 times. So maybe they don't need extra time. Maybe they just need someone who's like in the room with them to kind of make sure that they're feeling okay, you know, whatever it might be. And so those testing accommodations, you would also want to think about, do they need them for things like MCAS? For high schoolers, do they need things like that for the SAT, or, you know, some of those standardized tests? And then for services, if we sort of think about in the delivery grid of an IEP, there's consultation services, there's services in the classroom, and there's services out of the classroom. So that sort of consultation piece would be reflected in the service delivery grid, where if, let's say, the student is meeting with the school psychologist every week, we would want there to be a consultation scheduled between the school psychologist and the classroom teacher, so that, let's say, they're learning a new coping skill in their counseling sessions, we'd want to make sure that the classroom teacher is aware of that, so that they can encourage the student to use it when they see them getting maybe stressed out in class, to encourage that carryover and generalization of skills. When we have students who are already in therapy privately, we always recommend that there's a consult between the private therapist and the school psychologist or adjustment counselor, because again, there's that, like, you know, like Moira was saying at the beginning, kids are not in a vacuum. And so if they're just like making it through the school day sort of white knuckle and not talking to anybody, but then they're in private therapy, they're not necessarily taking the skills that they're learning in therapy to school, unless the people at school are kind of kept up to speed of what's happening. Like, okay, this is what they're working on in therapy. Maybe they're not meeting with the counselor in school, but the private therapist could, you know, have consultations with the school psychologist, so that everybody's on the same page, right? We want that sort of, we're all on the same team for this student. So you can go ahead to the next one more. So then if we think about things in the classroom, so those would be what we think of as push-in services, or for those who know IEPs, you know, grid B in the service delivery. And so sometimes I'll see counselors come in and either sort of work with one student or do some small group activities in the classroom. Maybe there's, you know, these days there probably are 3 or 4 students in the room who maybe are all struggling with anxiety. And so the school counselor could come in and do some push-in. I've also had many students who their anxiety is so impactful that it's hard for them even to be in the classroom. And so they might need an extra support staff with them throughout the day, whether that's like a one-on-one paraprofessional or an aide or teaching assistant who's like shared among a few students, but they just need that extra set of eyes on them, sort of keep looking for those signs of dysregulation, those signs of anxiety that we were talking about earlier. And then, you know, I'll recommend this a lot if a student is working with the counselor but still getting stressed out in class. That's where the paraprofessional can help with that. Remember, let's count to 10, let's go into the calming corner, let's, you know, reminding the student of their strategies. Because what we see a lot in kids who have anxiety is that it's like everything they could, when they're calm and in a comfortable place with a comfortable person, they could probably explain cognitive behavior therapy to you. You know, they could like tell you everything that they've learned. But when they're in that moment and the panic sets in, it's like it's all gone. And so having that extra staff person there to sort of remind those kids whose anxiety just kind of floods them can be really helpful with that generalization. And then there would be, you know, the pull-out services. So I've been talking a lot about, you know, kids who do go to the school counselor's office, whether that's weekly, every other week, whatever it might be. It could be individual or in more of a group setting. And, you know, I think we often think of social skills groups as being maybe for kids with autism spectrum disorders or developmental disabilities, but a lot of kids with anxiety struggle socially as well. And so sometimes those social skills groups that are more about sort of self-esteem building and like self-awareness and perspective taking, those, if it's sort of the right cohort, those can also be really helpful for kids with anxiety too. And for them to maybe, especially if they have social anxiety and maybe have a hard time making friends, something like that can feel like a safe place where now I connect with some other kids and maybe they carry that over, into the cafeteria or whatever. So sometimes a group session, I think, because sometimes I see a lot, and I'm sure Moira sees a lot too, is kids with anxiety sometimes resist services because they don't want to look different, especially if they have that social anxiety where they feel like everyone's going to know that I'm going to the counselor. They're going to think I'm crazy. They start to, kind of get in their head about what other kids are thinking about them, when we all know that most teenagers are just thinking about themselves. They're probably not thinking about that, but for the anxious kid, that can be really hard. So if it's more of a group format, I think that helps take away some of that feeling of like, what's wrong with me? Why am I, needing therapy and that kind of thing. And so like any thing that we're thinking about for level of service, the least restrictive environment applies to what we're thinking about for kids with anxiety. So, if they can be in the general education setting, that would sort of be obviously where, like, our goal. If they can't, can we have them spending some time in a smaller classroom? And then there are the students who cannot do that. So if you go ahead to the next one, more, this is my sort of last little slide, and then we'll get to questions. So there are students whose anxiety and or other challenges that are going on. The anxiety, again, might be sort of part of a larger complex profile, and they have every service that the school can offer. And they're just not making progress in a mainstream classroom. And so within a lot of districts, there are therapeutic programs. And so, especially larger districts have different programs sort of that are geared towards different populations of students. So a therapeutic program would be more for students who haven't identified, like, emotional disability, kids with anxiety, depression, things like that. And so I've definitely had a number of students who do what we would consider a partial inclusion, where maybe they go to the therapeutic classroom at the beginning of the day. There's a special education teacher in there, usually other support staff. They might start with like a check-in, maybe some group work. Let's preview the day. Let's talk about how you're feeling, that kind of thing. Then they go, depending on their academic level, then they would spend a chunk of their day in a general ed classroom as much as they're able. And if it's a subject that's particularly harder for them or whatever, they might go back to the smaller room for maybe some small group math or reading or whatever it might be. And so they're going back and forth. Other students maybe just can't be in the mainstream classroom at all. And so they're spending maybe their whole day or, 80% of their day in that smaller therapeutic classroom. And then, Maura and I have seen many students who have maybe been in a situation like that, and we're just still not seeing progress. They're still, sort of emotionally very fragile, not making progress, not learning coping skills, whatever. Maybe depression is worsening. Like, there's a lot of scenarios that I could go that I won't go into, but for whatever reason, that even within the district's maybe substantially separate program, we're just not seeing progress. And so those are the students who might need a specialized school or a specialized program outside of the district. And so there are, and again, that's going to depend on what the student's profile is. And, if we do have a student with more than one issue going on, so maybe a student who has an autism spectrum diagnosis and anxiety, would a school for students with autism be more appropriate for them, or would a school more geared for kids with anxiety be appropriate? It's going to depend on their profile, their, communication skills, academic skills, all of that. And then even within therapeutic schools, they sort of specialize in different populations. So there's a lot of factors that would go into something like that. And that's obviously, usually students get to this level after several years of sort of failed interventions, which can obviously be really challenging for everybody, the student, the teachers, and the parents. And, one of the things that we will see with those kids who have failed is that sort of compounds the trauma, and can make the anxiety worse. And so then they might need that more specialized setting for a while till they stabilize, and then maybe they'd be ready to go back to a larger setting a few years down the road. But that's going to depend a lot sort of on where they are and how they respond to treatment. So that is what I have for sort of the school part of things. And then our next slide, I think, is just questions. And I don't know if we want to have our contact information up or how we want to do this part, but I will pause and let Jane hop on.
Sure. We've had a lot of questions throughout the presentation, which is great. So what tools do you use to help support a child who has executive function issues?
Sorry, I was trying to click on mute and I was clicking on questions. Is this audio okay? I didn't realize until partway through. Okay, good. So I would say for executive functioning challenges for kids, in elementary school, there's a lot of supports that are already offered in the classroom, things like visual schedules, things like agenda books or homework sheets that might list what the homework looks like for the week. But when students hit middle school and high school, they strip a lot of those supports away. So a lot of times what I recommend to families is requesting accommodations to make sure that those planning elements are included. And one of the biggest challenges is that assignments and instruction for homework is often spread across multiple technology platforms. And so that can be really challenging. So there are students where we recommend that they have executive functioning class or an aide to provide executive functioning supports in school to be able to go through the assignment list, make sure they're staying up to date with what they need to do in their tasks, and planning their due dates across multiple days. And the goal, I think, for teachers providing this special education instruction is to be acting like the metacognitive system, to be teaching children how to think about studying and how to think about thinking. So we are teaching children how to construct their own checklists by letting them see ours as we go through how will we plan out the week and what activities will we navigate. And so that's one of the ways that we can incorporate executive functioning supports either in accommodations or in instruction with a special education teacher. I also think there's some good resources that are outside of school that you can pursue. So there are private executive functioning tutors. And there's all kinds of books, I think, that provide some really good supports for kids. I really like the Smart but Scattered series personally. So you could take a look at some of those for ways to build executive functioning skills.
All right. Is OCD genetic?
So for all of our psychiatric disorders, it's a combination of genetic factors and environmental stress that we think is contributing towards these diagnoses. There's not one answer, as it's only genetic, it's only environment that can produce OCD symptoms. What I can say is that there are a few disorders where it feels like the genetic load really contributes towards that, and OCD is one of them. So if you do have a first-degree relative that has obsessive compulsive disorder, then it is a greater likelihood you would pass it along to your child than someone who doesn't have obsessive compulsive disorder ending up with a child with OCD. But certainly I've seen kids come into my office who have OCD who don't have parents that have OCD. So it's not 100% ever either way.
Okay. And for a child who is hypersensitive and doesn't like to talk about feelings, how should they be approached if the next step recommended is a neuropsychological evaluation?
Do you want me to go, Erin, or you go ahead?
So, I mean, I think that, so in a neuropsychological evaluation, I think sometimes it is like less scary than going to therapy in some ways, because typically we start with, or at least this is how I do it. Maura can probably talk about how she structures her evaluations, but while I'm letting the student feel comfortable, we do sort of a lot of like the structured cognitive tasks. And I just, I sort of couch it in like, we're seeing how your brain works and how you think and how you learn. So we have some time to sort of establish rapport with the student before we would ever, like, we wouldn't meet them and be like, okay, so let's talk about why you're not getting to school. Like, we would put the more emotional part of the evaluation after the student has had some time to get to know us and feel comfortable. So we do our best, to do that as much as we can. I've had students with, like, who literally don't talk to me, who have selective mutism, who will only answer like whisper to their parents, and then the parent tells me what they said, so there are those kids, or the kids who are just very shut down, very withdrawn. And so that's sort of the case where we get as much as we can from the student, but in those cases, I'm also relying a lot on parents, teachers, other caregivers, if a student is doing therapy or anything else, getting their input. So we're always trying to get collateral contacts as well, because I mean, that definitely happens, that we're not going to get a student to open up with us after only knowing us for a few hours. So that's where that collaboration piece that we were talking about at the beginning is so important to us, because we want to hear. And also, I mean, like, we have kids who are delightful in our office, they participate, they're lovely, and the teachers are like, this kid is like under his desk throwing pencils at me it's like they can look really different at school. So we try to get all of that from everyone who knows the student. And then we even if a student never reports any anxiety to us, we would have the data that we need from other sources to make that diagnosis if we thought it was appropriate.
Okay, if a student is showing symptoms of anxiety and also has a history of trauma, what would that still be diagnosed and supported in the same way if the actions are not necessarily excessive given the history?
So I would say for that one is that developmental trauma is so complex and it is so impactful on a student's daily functioning. And I think of developmental trauma as not just being like trauma with a big T. I sometimes think of it, right? Like a really traumatic, scary event could happen to a student for sure. Or a student could be in a really have a history of care before they've arrived with adoptive parents, or they've been in a situation of physical or emotional abuse. Those are the big obvious traumas I think we think a lot about when we think about kids with developmental trauma. But there's also a lot, as Erin alluded to, there's a lot of trauma that can come from students failing multiple times of interventions and failing programs at school, or from having a poor fit in their reaction to those around them. Like, I've had some kids that get kicked out of camp every summer or have big explosive behaviors in front of their peers, and the reaction that they get over time when that builds up can feel traumatizing. I also have seen a number of students who've had peer trauma, where it's bullying that happens chronically, or it's constantly being left out or whispered about. And so those are all traumatic experiences for students. I also see some students where their sibling actually has quite a lot of needs, whether that's learning needs, neurodevelopmental needs, emotional needs, and being in the household with that person can create trauma reactivity. And so I think when I'm looking at a student's development over time, this is why I'm gathering all that information like Erin is just talking about, because that's also trauma. That also impacts, the research really tells us that impacts our attentional system. It impacts our self-regulation and arousal system. It impacts our, emotional foundation. And so any of those experiences for a student would certainly come under that developmental trauma. And so while it's not excessive to the situation, right, we'd expect anyone to have that kind of reacting. If it's continuing and it's impacting their daily functioning, then I wouldn't hesitate to identify that for a student to be receiving the supports that they require.
And how do you advocate for your child if they present differently at home than they do at school?
So I think something that we talk a lot about as a group is like generalization of skills. So if we have, and that's related to effective progress. So if we have a student who is fine at school, like I would say I see this scenario a lot. They're fine at school because they're not causing problems, but then every day when they get off the bus, they're having a meltdown, they're screaming, they're crying. Every morning is a struggle to get them on the bus, but then they get to school and they're just like so motivated to do well. So in those cases, I make the argument like this child is not okay. Imagine being at that level of hyper arousal and anxiety all day. Like think of as an adult, like being at work and just like trying to make it through and then going home and like, feeling mentally exhausted. And so those students who are displaying the symptoms at home but not at school are still in need of support. And those might be the kids who don't get the IEP. Maybe we can work on getting a 504 plan with accommodations. But I would make the point in my report, like, this is not a sustainable situation. And ultimately it's going to come out somehow, whether it's school refusal, whether it's an eating disorder, whether it's substance use, whatever it might be, it's going to come out somewhere else if we don't get the students some supports. I don't know if would you say anything different about that, Moira?
No, I totally agree. And the other thing that I would add, being a parent myself too, is our thought is that we're always trying to protect teachers and not bother them always with some of the small things that are a struggle. And so I really think it's important for parents to make sure that they're letting the school know when things are hard. And when a student is struggling over homework, so if I've presented homework to my child and they flipped out and now they've engaged in this big behavioral tantrum, or they're so anxious on Sunday night, I can't even get them to go to bed. So they go to school on Monday morning looking like a zombie. All these little stressors that are along the way that many times parents just hold on to and don't talk about. I think it's really important in any school-based meeting, whether it's a 504 or IEP meeting, to bring those up, a parent-teacher conference, or don't hesitate to email a teacher, because when you need to advocate that you need more support, it's better if you have that documentation over time of how that problem really is pervasive and affecting a student's life. And so I find that that's one way that can be really helpful, is to make sure that you're letting your team at school know when things are that hard. And don't be caught in the trap of doing the homework for them or making excuses for them or doing the pieces. Like a teacher doesn't know your child is struggling and doesn't know the homework and has sobbed over the whole thing for 3 hours if they get a pretty complete worksheet back. And so I think it's really important to make sure it's documented, but also if the homework can't be completed, you send back in what you've got, because then it makes the problem, someone's more likely to be aware of that problem, is what I would add.
We have another question. One major topic that I see that is missing is the anxiety and trauma that relates to racial trauma. The fight, flight, freeze, or fawn of accepting racism in order to be accepted or to have a job or to be on a sports team. Racial trauma has biological ramifications that are passed down generationally. I see too many times as this put off as bullying. Have you ever diagnosed or treated racial trauma?
So I would say that in elaborating on what I had commented on before related to trauma, I absolutely would see that as a form of developmental trauma that impacts a student, no doubt. Particularly, I feel like the world around us, politically and globally, is really overwhelming in the past several years for students. So I think that is a developmental trauma topic we have to be really careful about and aware of. When I'm asking families about experiences of stress or adverse events, I'm opening up the conversation to any of those categories of trauma. And I think that I would call it developmental trauma, right? I mean, that's a hard one, because when we get into diagnoses, it's like, Do we call this PTSD with these very strict criteria, or there's another category that's called trauma or other stressor related disorder? And in some ways, that's an academic distinction that your neuropsychologist would have to think about. Either way, it's developmental trauma. And so I would make sure that that's diagnosed and appropriately captured, because as you mentioned, it has biological ramifications on how a person's neural connections are built, and how that can be passed on. And it's really important in building healthy relationships and self-advocacy and a sense of safety to know about that as a part of someone's profile. So that's a good question.
Great. Consider, this is asking to provide tips for IEP services and accountability for those. In addition to getting the services in the first place, having it on an IEP document is only one piece. Any recommendations for making sure that the district is being accountable?
I mean, I think that, I will often, especially if a student is really struggling, like I'll remind parents that, they can request a team meeting at any time. And the other thing that is important, like Moira was just saying, is like document. So you're right, a student has an IEP, but maybe you're concerned, like, okay, they're really not clicking with the counselor, or they're not like using the skills, or whatever, you might be concerned about that's not happening, or the paraprofessional, there's not a professional in the classroom, even though it's in the IEP. So keeping records, of sort of sending emails to the IEP team, sort of expressing your concerns. And that's, just kind of the way that you need to keep advocating. And I know that it's exhausting, and, you do as much as you can, but trying to, talking to your student about what did you work on with, counselor so-and-so, and trying to get information about that, and just keeping the lines of communication open with the team as much as you can is, I guess sort of my best advice about that. And don't wait till the annual review to suddenly say, okay, I've got these 25 concerns from the last year. Keeping it going throughout the school year is the way that you're going to let the team know that you're still really worried, even though these things are in the IEP.
Does the consult with the private therapist go on an IEP?
I think you can have in the service delivery grid, consult with outside providers can be listed in grid A, right, Maura? You can specify that for consult. You wouldn't like name the therapist in case it changes, but you can have a consult with outside providers listed on there.
I think that's especially relevant when we have some of the more complex cases where treatment really the majority of treatment really needs to happen outside of school. So I'm thinking, for example, of like a child who has significant school refusal, or who has selective mutism, or a specific anxiety disorder that even a very well-trained and well-meaning school counselor may not have a tremendous amount of training and expertise in. And so consulting with an outside provider who's an expert in that domain would be really critical to document. I think if I was imagining a student who had kind of a generalized anxiety disorder presentation, documenting it in grid A of the IEP would feel less urgent to me. But certainly for some of those other more specialized services and types of therapy, I would try to push it to be in there, because I do think that then you're not the only one advocating for your child. You also have an outside provider who knows about those kind of behaviors, who's also acting like a system of checks and balances too, to make sure that those services are being delivered.
Can you recommend any groups that are geared towards anxious kids?
Where can that person let us know where they live? Because that would probably, there's a lot in the Boston area.
Okay, I'll see if they write back in.
Sorry.
No problem. If an intention is for students to complete homework in 30 minutes and it takes a student with ADHD and anxiety 3 hours, would decreased academic demands be an appropriate accommodation while other management strategies are being worked on? How would that get written into the IEP, and how could that be implemented?
So I usually put in decreased homework demands in an accommodation. And I write, so that's one of the things that I write, and I list in their emphasis on quality over quantity. One of the things I think is really important sometimes for perfectionistic students is I see a lot of times when teachers will say, well, do as much as you can in that 30-minute window and leave the rest of it unfinished. For students who have a really anxious, social anxiety, perfectionistic presentation, that can be really difficult to leave information incomplete. And so I will often write the recommendation that teachers need to shorten the length of the assignment, not leave it up to the discretion of a student. Or I'm going to have a student who's up until 1 o'clock in the morning, obsessively checking and doing their homework. And so I often am careful in the accommodation to say decreased homework demands, and length should not exceed, whatever the amount is, and that, and it's not just based on time, it's based on a task, so that a student can feel like they've completed the task. So that's something else to kind of keep in mind. But 3 hours for a 30-minute homework assignment, you're right on that. That's way too much, and that's way too stressful for a student. They get no downtime. It limits their exercise. It limits their ability to enjoy their meal, to have a restful sleep. So let's reduce that as quickly as we can.
And the question about groups for anxious kids, we have one area is Acton, Concord, Waltham, and Newton area, and then another participant who is asking about that for Hingham and the South Shore.
So in the Newton area, one of the places that we recommend a lot is called the Academy for Physical and Social Development. They also have a location in Natick, which is called the Academy Metro West. So they do a lot of group-based work for kids who have anxiety disorders. And a lot of it has sort of like collaborative team building approach. So it's working on things like, tolerating losing and being okay with taking turns and collaboration and things like that. So that one comes to mind sort of in that area. There's also, if it's a student who is struggling more socially because of the anxiety, there's a clinic called Social Thinking Boston that's out of Sudbury. And they're based in the social thinking curriculum that I was talking about, but it's not exclusively for kids with an autism diagnosis. So those come to mind. I don't know if there's others that come to mind for you, Moira.
Those are definitely ones that come to mind. One of the things I think is so challenging for families, and you may be asking this question for this very reason, is that there's a real difficulty in the community of locating services for students, finding outpatient therapists, finding therapy groups. And it's the squeaky wheel that gets the answers and gets on the waiting list. So I would say a lot of families are turned off when they hear that there's a waiting list. Put your name on the waiting list, even if you've got your name on 6 waiting lists for people. So that's always what I recommend. And contacting the school psychologist too is another helpful domain, because they often maintain a list of some providers in their community that may have them. And I'm trying to think, I can't exit my screen right now because I'm the one who has up some of this information, but I'm happy to follow up with someone about some specific South Shore recommendations, as I'm myself trying to get to know some of the community-based services that we have. So I'm happy to follow up there if you want to shoot me an email so that I know that it's you.
We had another question about the North Shore too, and we can probably reach out to Angela Curry in Londonderry and see if there's any recommendations that she's interested in, and also for Andover. Let me see. And for those folks who are interested, please feel free to email any one of us, and we can try to help you out with some of those groups. How important is it to have an advocate at an IEP meeting? What are the benefits?
I think that most advocates have the goal of helping you craft the most useful IEP for your student. So they know the law and sort of the regulations that the schools should be following. And also going back to the other participant's question about sort of accountability, I think having an advocate can help you with that, because it's sort of like someone who can be kind of a bug in the ear of the team, where they're like maybe helping you write emails, or they're writing the emails themselves, where it's like, okay, we got that consent form however long ago, but it hasn't happened yet. Can you give us a status report? You know, that it's kind of their job to be on top of stuff that maybe you, as a working parent who has a gazillion things going on, you've missed a deadline. You know, that's where an advocate, I think, can be helpful. I think the other piece of it that's helpful is, you know, most parents get very, or feel emotional in meetings, because it's like, this is my child that we're talking about, and having an advocate there to sort of help with that, like, they are just going to try to stick to the facts and sort of like, let's get this wording right, and they're not as emotionally invested as you, so it might just make the meeting more tolerable for you emotionally, I would say.
And most advocates, their goal is, oh, sorry, Jane. I was just gonna say, most advocates, their goal is collaboration. And so we always want for students and for families to feel like they have a relationship that holds up with their district. Because ultimately, even if students go all the way down the pathway that Erin has described and they are placed out of the district, you live in the community. And so I do think that it's important to maintain as much of that positivity in a relationship that can happen. Certainly, we've seen cases where that becomes really eroded and deteriorated, and then an advocate is really helpful in that situation. But the goal is not to get there. And so I do think that there's times when advocates can be really helpful. Sometimes families opt to bring in neuropsychologists to present their testing data. So that's something else that you could consider. But the benefit of an advocate would be that they can provide information moving on, right? Like, rather than this is sort of my area of like, here's the report and what we want to put in place for services, the advocate's there to really support you with the follow-up. And so that goal is that collaborative relationship for as long and as much as you possibly can do with the district.
We have another one where my child is autistic with a PDA profile and high anxiety has led to school refusal. There aren't specialized schools nearby, not that he'd agreed to go, and the district is struggling to support us. Are there any suggestions for next steps?
I think that's challenging, and obviously would depend a lot on kind of what's already been tried and the student's profile. I think that, you know, we're seeing, or I see a lot of kids on the autism spectrum, and I think because of that, I also am seeing more kids who have PDA, which is still, you know, it's one of those subsets that isn't as well understood, especially in the US, where we're sort of not using that terminology, but it clearly describes a lot of students. And I think kids with PDA fall into that category of, it's like the extreme fight response, right? Like, they can't tolerate any level of distress, and so they are refusing anything that they perceive as stressful. And so that's getting seen as, these are behavioral kids, as opposed to these are kids who actually have really deep-rooted significant anxiety and no distress tolerance. And I think for a lot of students where it has gotten pretty severe is that they will often need a more specialized program sort of to get stabilized before they could go to sort of, I guess, a lower tier of intervention. I'm not sure where you live, but I think some of the sort of trauma-informed schools, like I'm thinking of Dr. Franklin Perkins School, which is up in Lancaster, they have a lot of students who, you know, have sort of had that historically challenging profile, and you know, other schools that would sort of understand it as, we've got to work on the coping skills. I think it's hard for us to sort of say, oh, look at this school or that school, because we don't know your student. But I think that casting a wide net, and if your student has someone that they work with outside of school, whether it's an OT or a speech language pathologist or someone who sort of knows them well, to be in touch with different admissions places to help describe, your student's profile better than you can sort of see on paper, if that makes sense. And I know that that's probably not a great answer, but it is challenging, and then finding the right school, I know can be difficult. So casting as wide a net as you can. And there could also be programs out of state. Moira and I have definitely seen our share of cases who end up going to, whether it's like a wilderness program or, another type of specialized place that's not necessarily in Massachusetts, that you probably need to work with an educational consultant who has maybe knowledge of the greater New England area, if that's something that you would be willing to consider.
Can you talk about how to identify kids who internalize? They don't have outward expressing identifying symptoms and have anxiety and corresponding accommodations in the classroom.
So I think that that's where it's so critical that we're doing not just measures of anxiety, but we're also doing a lot of testing in the room. When we're doing a neuropsychological evaluation, it's 5 to 6 hours of different kinds of tasks. And both Dr. Gibbons and I are doing all of our own testing, right? So that's something that's unique about NESCA, is your neuropsychologist is the one seeing the student right in front of them. And so I'm looking for the signs of that anxiety, and I'm asking students about it. One of this links to another question that someone had previously about what happens for the kids who may be reluctant to talk about their anxiety, those internalized symptoms. I actually find that a lot of times those students are more comfortable filling out the questionnaires about anxiety rather than talking about their anxiety. They can list it when it's on a form a lot easier than they can say it out loud to someone. So we're trying to capture anxiety that way and providing different methods of assessment, whether it's observation, and looking at how does someone do on time versus untimed tests, because that can generate anxiety, looking at how someone self-reports their presentation of symptoms, and then how parents, who usually have a better pulse on those internalized symptoms than a teacher might in a larger classroom, we're using those pieces of data to try to inform that decision for an anxiety diagnosis.
Right, and I think we have time for one more, and then I apologize, but we are going to have to break, and we can follow up via email after this. Can you speak more about anxiety comorbid with ADHD? I understand how and why they co-occur. I don't feel like I have a good understanding of when the anxiety requires specific attention or intervention apart from the ADHD.
Erin, I'll start and then you can jump in if you want to. Does that sound okay? Okay. So what I would say is it's really important for me always to know if there's a comorbid anxiety disorder diagnosis, because one of the common treatments that we use for ADHD are stimulant medications. And for somebody who is really anxious, that can sometimes exacerbate the anxiety. And so I think it's really helpful to know what the level of anxiety is. So I'm knowing if it's pervasive, if it's interfering with functioning, if it's excessive or out of proportion. What I see happening a lot of times for students is, how do I want to describe this? For those that I'm less worried about a separate anxiety disorder, and I'm going to lump it under the umbrella of ADHD, I'm going to describe those students as ones who sometimes get stuck on an anxious thought. It may pass through their consciousness and half the things fall out because they have ADHD and half the things are like really hyper-focused. So if that is when the anxiety pops up and then it kind of goes through and that anxious thought may not come back, it might be a different topic the next time, then I'm less likely to think that it's an anxiety disorder also. I am more inclined to think it's an anxiety disorder also if that anxiety does become more pervasive in multiple environments, and it feels like the anxiety, that report of worried thoughts and behaviors to avoid the anxious trigger start to really impact someone's functioning. So that's when I'm thinking more about it being a comorbid anxiety disorder and really trying to help a student with anxiety, because executive functioning coaching isn't going to help. That's going to address a lot of the ADHD-like symptoms, but that's not necessarily going to get at the need to pay attention to some of those anxious thoughts, reframe some of those anxious thoughts, some of those CBT techniques that we might have to help a student challenge those anxious thoughts and reduce their physiological arousal. You don't pull that in naturally with ADHD. And so I think that comorbid presentation will be really important to look for. Anything you would add to that, Erin?
I mean, I think where we're talking about that overlap of how the anxiety is going to impact like executive functioning in the classroom and things like that, then there is a lot of overlap in some of the accommodations we'd be talking about, like, you know, access to breaks and maybe quiet room for tests and things like that. It would sort of be, it's one of those like, is it because of the ADHD or the anxiety? It's sort of like, well, it doesn't matter necessarily where it's coming from. This student is struggling with both of these, and this is how it's impacting him. So, but like Moira was saying, some of those direct services, like I wouldn't necessarily want an IEP goal for, you know, emotional coping in a student who had ADHD, but not anxiety. Whereas if I know that they have both and they're struggling with both, I'd want to see that they are actively working on their coping skills during the school day as well as outside of school. So I think it sort of would relate to what goals we're talking about and what specific skills are being targeted.
Okay. Well, thank you everyone for participating and listening in and for your excellent questions. We have recorded some of the questions and hopefully we'll be able to answer some of those. We can post some of those answers on Facebook if that's helpful. If you are not on Facebook, we can certainly answer them by email for you. If you want to just get in touch, and Dr. Creedon and Dr. Gibbons' emails are right here on the screen. Hopefully you've had a chance to take those down, and feel free to send those along. And again, we just thank you so much, all of the CPACs and all of the participants. I hope it was helpful, and thank you to Dr. Gibbons and Dr. Creedon as well. Thank you.